Hi everyone, welcome to another episode of the Interstitial Lung Disease.info podcast. In this episode, I'd like to discuss a little bit about how to take a history and how to conduct the first consultation for an interstitial lung diseases clinic, because I think that's really important to try to get the most information that you can out of the time that you spend with your patient, especially when you have a new referral for interstitial lung diseases. This structure of the consultation is something that I personally use, and it's something that we generally use in the interstitial lung diseases unit where we work. This is in Manchester, UK. Now, obviously, this may vary around the world depending on how things are organized, how much time you've got available, what's the usual routine for seeing interstitial lung diseases patients, because in some places you may not have dedicated ILD clinics. People who are suspected of having different kinds of lung fibrosis, they may be seen by general respiratory consultants or pulmonologists. So in that case, the consultation may be run in a different way. But I'm just going to go over what we tend to do. Again, this may vary according to the place where you are in the world. This is something that we do, basically. So let me give you a little bit of a structure. So I'll cover what are the main things that we discuss with our patients to try to collect the information in a standardized way. And this is generally reflected in the letters that we give out to our patients and that we send to other health providers, in a sense that if we follow this structure, we tend to have a harmonized template for our letters, and then when we are looking for specific bits of information, we tend to find it much easier. This has been our practice. So when we come to discussing cases in the multidisciplinary team discussion in the MDT, it's very easy if we've got our letter in front of us, printed out or on a computer screen, we know where to look to find the exact information that we're looking for. So this is basically the structure that we use. I'll just get into it without further ado. So we tend to first discuss about chest symptoms, then the timeline of these symptoms, other symptoms, which may not be related to the chest. We talk about medical history, past medical history, medication, and a timeline of when medications were started and stopped, smoking history, the occupational and environmental history, family history, very important, and then we do a physical exam towards the end. So this is basically our structure, and I'll just go over these little parts in more detail so that you can understand a little bit better what are the questions that we ask. So when we talk about chest symptoms, this is normally when we start the consultation. So first of all, we obviously set the scene. Why, if the patient's been referred to us for an interstitial lung disease review, we tend to explain a little bit what's going on with this clinic, what to expect, what we may discuss about. We warn them that we may actually have to ask them a lot of questions. But then we tend to move on quite quickly into the symptoms. So we tend to ask our patients what sort of symptoms they have in terms of their breathing. Shortness of breath is the main symptom that we ask about, and we tend to try to quantify their breathlessness in some as objective as we can, of course. So different patients may tell you different things, but we tend to prod a little bit and try to prompt them to give us an estimate. So for example, how many flights of stairs can they climb before they have to stop or before they get breathless? Or how far can they go on the flat? Do they get tired when they go up steep inclines, or can they go for an unlimited amount of time? And then we try to determine how has that been progressing over the last, let's say, 12 months. If our patient tells us that they've been breathless for years, we may try to understand what has been going on more recently. And the reason why we ask this question is obviously because we want to know how badly our patients are affected by their symptoms, but also it has implications on prescribing certain medications. So for example, if we are considering prescribing nintedanib as an antifibrotic for progressive fibrotic interstitial lung disease, in the UK at least, we need to show that there's been symptomatic progression over the last 12 months. So we tend to ask specifically for that. So that's the reason why we ask that. And then when we think about follow-up consultations, if we plan ahead a little bit, we know that patients with interstitial lung disease will tend to be followed up over time. So when they come to the next consultation and they say that, well, their exercise tolerance has dropped from, let's say, 200 meters on the flat to 50 meters on the flat, we know that they've had a pretty significant drop. And that's even before we need to do any lung function or anything like that. We also tend to ask about coughing. Do they have sputum production? Is the cough happening daily? Is it dry cough? Is it triggered by anything specific? So, for example, is there maybe a cough that's triggered when they lie flat in bed or after a big meal? Or could it be associated with acid reflux, with post-nasal drip, things like that? So we tend to ask these questions just to understand a little bit better if the cough that our patient is experiencing is only related to their chest, to their lungs, to their fibrosis, or is there anything else that might be explaining it? And then we tend to ask about other respiratory symptoms, such as wheeze. So wheeze is a very important symptom, especially if we're considering that some of our patients may not have only IPF, as idiopathic pulmonary fibrosis. They may have, for example, chronic hypersensitivity pneumonitis. And in that case, a wheeze may be present. Or they may have asthma, which is actually responsible for much of their symptoms. Maybe it's not, the fibrosis is only a component of their lung disease. So we tend to ask about these sort of symptoms specifically and ask our patients to try to establish a timeline of how these symptoms progressed over time. So that's, I think, really important for us. Then we do ask about chest infections. So are the patients experiencing a lot of chest trouble? So do they need to go to their general practitioners, to their family doctors to get antibiotics for a lot of chest infections? Are these chest infections really chest infections, or are they sort of flare-ups of their interstitial lung disease? So we try to tease out what's going on. We try to determine the functional status of our patients. Are they in and out of hospital a lot? Are they struggling at home? So these are quite important topics to cover, maybe at the beginning of the consultation, to understand exactly what the picture, the overall picture of health for our patient who is suffering with ILD. Then after this part, where we focus on the chest a bit more, we tend to think about other symptoms. So we move away from the chest and we specifically ask our patients about other symptoms that may be suggestive of connective tissue diseases. So do they have any rashes on their skin? Do they have joint pain? Do they have joint stiffness in the morning? How long does it take for them to get going in the mornings? For example, if they tell us that they have pain in their fingers and their joints are a little bit stiff in the morning, does that last for more than half an hour in the morning? That's quite relevant for the presence of connective tissue disease. So things like rheumatoid arthritis may be revealed in that way. And this is something that I've been wrong about actually in the past, because rheumatoid arthritis can actually first start to show symptoms that are not necessarily joint predominant. They may have lung involvement first. So then the joint involvement may happen later, or may be coincidental. A lot of people may be suffering with rheumatoid arthritis and not know about it. So quite important to ask about the joints. Also, are there any other symptoms present? Raynaud's, for example, Raynaud's phenomenon, if a couple of fingers are going white and in the cold, things like that. Patients will tell you that. At that same moment, personally, I tend to look at the patient's hands and fingers and figure out if there's any evidence of mechanics hands or any cracking of the skin, splitting of the fingernails, things like that. So we tend to look for these sort of signs of connective tissue disease as much as we can. And we do ask about acid reflux as well, which can be relevant if there is extensive fibrosis, if we may need to treat that one. So these are some of the things that we ask in this part, where we ask about general symptoms. Also, sometimes we may ask about weight loss, as many of our patients have lost a lot of weight. This again may suggest that there may be other conditions going on. There may be chronic inflammation in their body, but also it's really relevant if we are considering treating with antifibrotic medication. So both pirfenidone and nintedanib, well, there's a relative contraindication to prescribing them to patients who have been actively losing a lot of weight, because it may worsen this problem. And our patients may actually have very poor outcomes if we give them these aggressive therapies that have digestive complications in some cases. Once we're done with the symptom inventory, let's say, we move on to discussing past medical history, any relevant conditions that they may have. So first of all, we start off with their current diagnoses. Type 2 diabetes is quite relevant here. Do they have an increased BMI? These are relevant if we need to treat them with steroids, for example, with corticosteroids, with prednisolone long term. we need to be careful not to destabilize their other comorbidities. We may think about heart disease. So if they suffer with significant ischemic heart disease, that again may be a problem depending on what treatments we need to offer. Is there aortic stenosis, for example, which may be responsible for much of the breathlessness for our patients? All kinds of things our patients may tell us. They may tell us about a history of other connective tissue diseases. So in that case, the diagnosis becomes a little bit easier because we are finding causes for their fibrosis. And then we discuss about their current medications. So are they already on corticosteroids, for example? Are they taking any immunosuppressants? Are they on all kinds of tablets? And we try to specifically think about medications that may cause lung damage. So if they've been on chemotherapy for a cancer, if they've had radiation treatment, I'm not sure if this falls under past medical history or medication or treatments, but if they've had radiation given for breast cancer, for example, it may explain some of the lung fibrosis on that side of the chest that was caught in the radiation field. So that's quite relevant. So all kinds of medications, if they have a lot of urinary tract infections, for example, and they take nitrofurantoin, that's a common culprit for lung abnormalities. Methotrexate, the word on methotrexate, I would say that methotrexate isn't that commonly associated with lung fibrosis, even though it's a popular knowledge among many physicians that it is the main cause of lung disease. And this is, again, coming back to rheumatoid arthritis. I probably need to make more episodes about rheumatoid arthritis and interstitial lung disease, because rheumatoid arthritis associated interstitial lung disease, or RA-ILD, can be present in a large number of patients with rheumatoid arthritis. And it's probably more common than methotrexate-induced lung damage in rheumatoid arthritis. Actually, the methotrexate in many of these patients, unless there is a specific timeline that as soon as they started methotrexate, they started feeling more breathless, they started developing chest symptoms, it's likely that the actual rheumatoid arthritis is the culprit and the methotrexate is helping to treat the rheumatoid arthritis and keeping the lungs better. So it's it's a matter of a lot of controversy. If you read the latest literature, if you attend conferences in this field of ILD, there's always a talk on RA-ILD and methotrexate, probably at all the recent conferences, at least up to now. There's a lot of controversy. I have a feeling that we need to be careful with this and not necessarily potentially stop methotrexate immediately unless we have a specific indication that it is causing the actual lung problem. So quite complicated here, but it's important to get a very good medication history with a timeline of when medications were started and stopped. And that can be quite time consuming. Many patients may not remember, especially if they've had all kinds of treatment given to them, especially in the case of cancer patients. They may be referred for interstitial lung disease evaluation because they have a lot of CT scans and they pick up a lot of abnormalities. And they've also had potentially a lot of crazy treatments. They may have had immune, checkpoint inhibitors and all these immune modulating drugs. These do have potential consequences in terms of developing interstitial lung disease. So quite important to get a very good medication history if you can, because you're trying to determine whether it's drug-induced ILD. Then we move on to smoking history. So we do ask our patients to quantify how much they've smoked for, when did they quit, if they smoked anything else besides normal cigarettes, if they, if there was a history of drug abuse. If you suspect that, you may ask that. We don't tend to routinely ask like robots whether our patients have been using all kinds of substances. You tend to judge by yourself based on your clinical experience what sort of questions you need to ask in this regard. But getting at least a minimal response whether the patient has smoked or not is probably quite relevant. After we're done with the smoking history, we tend to move on to occupation and environmental history. This is really essential because a lot of patients may have worked with asbestos in the past. So especially the patients that we're seeing in the interstitial lung disease clinic who may be in their 70s, 80s, when they were younger, they may have worked with asbestos. The regulations at this stage, so when we are recording this episode in 2022, obviously in the 1950s, 1960s, there was still asbestos around, even in developed countries. And in developing countries, there's still a lot of asbestos out there. And there are patients who may have worked on construction sites, they may have worked in asbestos factories, they may have broken up asbestos, but that it's important to quantify how much asbestos exposure there was. The reason why we ask about asbestos specifically is because it can cause a lung pattern of usual interstitial pneumonia. So it can sometimes be confused with IPF. You may think that the patient has IPF, but actually it's asbestosis if you dig down deep. Now, of course, you need to keep this under monitoring. So even asbestosis can lead to progressive fibrosis, which may be eligible for some treatments. But generally, I would say that if you have a significant asbestos history, you may not think about treating that as idiopathic pulmonary fibrosis, even though the CT scan pattern may be similar. We tend to ask about mold exposure, so that can also lead to some forms of interstitial lung disease, hypersensitivity pneumonitis. Is there a damp in their home, areas which are a bit moldy, musty, things like that? We tend to ask about that. We tend to ask about bird exposure, and it's important to know that many patients will not remember or may not think that their bird exposure is relevant. And here we tend to emphasize the fact that it's not the exposure to large birds or anything like that. It's to think about the fact that it's microscopic particles of dust that carry bird proteins, avian proteins, that actually cause the lung sensitization and chronic hypersensitivity pneumonitis. So some patients may not think about that. So they may say, oh, I just keep a little bird in a cage somewhere in the house, and it's fine. I've had those birds for 10 years. It may be relevant. Or other people may actually mention that they don't keep birds in the house, but they use feathered pillows, feathered duvets, feathered bedding, feathered clothes that contain feathers in them. So it's important to be quite particular about the avian exposure. It can be relevant, and a lot of people may ignore some obvious exposures. So I've had a patient quite recently who was telling me that they don't keep birds in the house, they don't have any feathered bedding, anything like that, but they did specifically mention that in the place where they keep their car, there are birds in the tree above, and the car is always covered in bird poo. And every time they turn on the car, the vents blow out air that smells like bird poo. So is that relevant for bird exposure? Potentially yes, especially because the patient had a radiological picture that was consistent with hypersensitivity pneumonitis, and their blood tests did show avian sensitization. So that's quite relevant, even in cases where the birds are not kept in the house. So it's quite important to ask about these things. But let's move on from the birds. I tend to ask about other humid environments where the patient may have been. If they go to swimming pools, saunas, these sort of places, you need to think about hypersensitivity pneumonitis. And it can be very, very difficult sometimes to find the antigen. But I have a feeling that part of that is because we don't really ask all the right questions. We tend to sort of blaze through the consultation, but we don't tend to focus on the environment where the patient lives. It's important not only to ask about their work and their home, ask about their hobbies. Are they keen gardeners? Do they keep a greenhouse? Do they work with pesticides? All kinds of things. Quite important to ask these questions. Once we're done with the occupational part of the consultation, I personally tend to ask quite a lot of questions about family history. And I did try to create some other episodes on the website, and I probably will do more because it's an area of interest for me personally to ask about family history. There is a lot of familial pulmonary fibrosis that's not diagnosed. Familial ILD is missed very, very often because we don't even ask about family history related to ILD. And it's not only ILD, it's a little bit more complicated here. Let's talk a little bit more in detail. So when you think about family history of ILD, first question you need to ask, is there anyone else in your immediate family, blood relatives, who may have had lung fibrosis? If the patient said yes, you need to get more detail. What kind of fibrosis was it? Was it after tuberculosis? Was it related to something else? If there doesn't seem to be an apparent cause for the fibrosis, even though the diagnosis was not formally IPF or something like that, you may need to think that that's relevant. Here, related to the family history, it's important to note the patient's age. So if your patient who is suffering from ILD is younger than 60 years old, I would say that you need to be very careful about asking a lot of questions regarding family history. It's quite early in life to develop pulmonary fibrosis, especially if the patient's 50, 45, things like that. You should ask a lot of questions about family history. And of course, we ask about familial fibrosis, but it's important to ask about any kind of lung disease, because your patient may not know, or they may be in a place where the fibrosis was never diagnosed. Maybe the members of their family never had CT scans or other investigations. But if they say that, well, 5 members of my family suffered with lung disease, and it was my grandfather, my father and his brother, my sister, and someone else is suffering with lung disease, but it may be called asthma, COPD. I would say that it's important to at least note that in your clinical history. The other thing I would ask related to family history is moving away from the chest and the lungs to think about signs of telomere dysfunction in the family. So telomeres are the ends of the chromosomes. They protect the chromosome during cell division, and telomere shortening is sometimes associated with premature aging in the lungs, which can lead to earlier fibrosis. This is really, really interesting. So first of all, there may be something called genetic anticipation. So if someone in the family had lung fibrosis in their 70s, let's say an uncle had IPF diagnosed at age 75, and our patient is 55, it may be possible that this is a case of familial pulmonary fibrosis related to telomere shortening, and there is genetic anticipation because there is an inheritance related to the length of chromosomes, the length of telomeres, And then if the telomeres are short, they tend to be shorter, faster as generations go by. So you may get these cases of lung fibrosis at an earlier age. In regards to the telomere dysfunction, there can be other conditions which may be associated. So aplastic anemia, for example, cases of leukemia in the family, these are relevant. If you have a lot of cases of autoimmune disorders in the family, again, very relevant family history. Unexplained cases of liver disease, liver abnormalities, again, very, very relevant. Early menopause before the age of 45, early gray hair before the age of 25. These are all relevant bits of information that should be present in a letter if you're trying to take an accurate family history. I think that's really important. And generally, I just end this section of the consultation by asking an open-ended question. Any other rare condition, unusual conditions in the family, anyone who may have experienced a lot of miscarriages, all kinds of things like that. I think that's really, really relevant. We conclude then the consultation with a physical exam, obviously focusing on the chest. Is there auscultation that's consistent with pulmonary fibrosis? So here you would think about fine crepitations on both sides of the chest, especially in the bases. That would be relevant for pulmonary fibrosis. And generally, if you have these fine crackles and inspiratory crackles, if you do a CT scan, you'll probably uncover fibrosis. So it's a very relevant clinical sign. You may think about finger clubbing. So that's, again, suggestive that there is an advanced lung disease. So that's quite relevant. You may look for signs that your patient may require extra oxygen. You take a look at their lips. Is there any evidence of that? Of course, we talked about having a quick look at their hands and fingers. Is there any crack? Is there any swelling in the joints, in their hands, in the small joints of their hands? Any cracks around the fingertips, the skin, things like that. So it's really, really important to get all these details down. And from experience, if you have a structure on which you just build these sort of informations, if you have the same sort of template for your consultation, you'll find it a lot easier and you'll go a lot faster than if you're just randomly asking the patient different things. So if you have a template, if you prepare a template, it doesn't have to be the one that I'm suggesting. So it could be your own style. Of course, every doctor has their own style. But as long as you manage to cover occupation, family history, drug history, connective tissue disease possibilities, and anything else that may have happened, symptoms, I think you're pretty good to determine what's the connection, what's the potential cause for the images that you're seeing on the chest that are suggestive of fibrosis. So this is basically a structure for a first consultation. From experience, it takes maybe around 30 minutes to an hour to get all this information down. I know that can seem like a very long time, especially in a busy clinic, but I would suggest if you can't do it all in one go, try to bring the patient back on a different day and discuss the rest, because it's quite important to have these bits of information before you go into the multidisciplinary team discussion to discuss the case. Or if you discuss with your radiologist, again, the MDT discussion may not be possible in all centers around the world. So it depends on local arrangements, how busy the service is, how willing other specialists are to participate in these meetings. But even having informal MDTs with other members of staff, so discussing with a rheumatologist what you have found, or discussing the images on the chest CT with a radiologist, is probably quite important to trying to come up with a good diagnosis. So this is just my take on how to do a complete, as much as possible, history in real life. Of course, we can give our patients questionnaires about occupational hazards and things like that. You can be creative with this and do it even better. But if you don't have the time, I think at least following the little bits of information that I suggested here would be very, very helpful to allow you to get a complete picture of what's going on. So I hope this was helpful. If you do like this type of content, do subscribe to the YouTube channel. Visit the website interstitiallungdisease.info. Leave a comment on the YouTube channel, listen to the podcast, let me know what else you would want to hear about, and I'd be grateful, I'd be happy to do more of this kind of material. Thank you very much for listening, and all the best to you.